So shortly, about 6 months or so after we got Ceribell in place, I really wanted to look back and see what did we get out of implementing Ceribell? Did we really improve our time to EEG? What departments were using it? Did we increase seizure diagnosis? And what happened with our length of stay? So we took a look at the 6 months prior to putting Ceribell in place and looked at our conventional EEG data versus the 6 months of Ceribell data. And that's what I'll kind of go through next. So did it improve access? Well, in the 6 months prior, we had only 35 conventional EEGs completed, whereas the 6 months post, it was 115. You can see, too, the areas. I mean, look at the ICU, 40 versus 16. CSU is our telemetry unit, so 41. Again, remember, we have heavy cardiac and vascular, so that kind of makes sense. And then our ED, now, while they didn't order one every single day in 6 months, they clearly were ordering more. And now, more recently, we've looked back at our data, and in fact, our ED is ordering a significant amount more nowadays. All right, and did we find more seizures? Actually, we did. 0 in conventional, which is not surprising since most of the time they had to wait a long time and were probably, if there was a high suspicion, already treated for seizure. But with rapid EEG with Ceribell, 23% of those detected seizures. So we were getting more seizures, which is great. We were finding them and treating them. So it really was impacting clinical practice. You know, and people ask me sometimes rapid rule out versus rapid rule in. Well, rapid rule out is just as important, right? Because we limit unnecessary treatment like medications for seizures that if they don't have it. Emergency department physicians have told me they can get the patient either admitted more quickly because they know they've ruled out seizure and they're kind of finding a new differential diagnosis, or even for some cases, the patient's able to go home. And then, of course, if we're not loading somebody on a heavy anti-seizure medication, we're going to reduce ICU admissions. For rapid seizure diagnosis, makes sense. We talked about the increased morbidity and mortality when we wait to give anti-seizure medications, and so we're going to resolve the seizure sooner. We're also going to capture diagnosis if clinical suspicion is low. So in the past, if the clinical suspicion was low, that really became the very last thing, and often the physicians just didn't even bother to order it because they knew they couldn't get it. And ultimately, it really is the best practice. It's the best practice because we know we can rule in or rule out seizures right away, which is important for patient care, so much so that, again, in this subclass of cardiac arrest patients, the Joint Commission has said it's a best practice and we want it to be followed.